Biological systems designed to build the human body can occasionally turn against it. In the skeleton, periods of massive physical growth require explosive cellular division, creating millions of opportunities for a single genetic copying error. Because of this vulnerability, the primary demographic affected by osteosarcoma, the most common primary bone cancer, is teenagers. During pubertal growth spurts, their long bones are elongating rapidly, making them uniquely susceptible to the cellular mutations that trigger the disease. This chart shows the bimodal age distribution of the disease. There is a massive spike in incidence between the ages of 10 and 25, followed by a long lull and then a distinct secondary bump in adults over the age of 65. While adolescent cases are driven by natural puberty, the older demographic develops osteosarcoma from alternative triggers. In patients over 65, the cancer usually arises secondary to conditions that force abnormal bone remodeling, such as Paget's disease, or from prior exposure to therapeutic radiation. Osteosarcoma relies on high cellular turnover, whether driven by an adolescent growth spurt or bone repair mechanisms of older adults. The disease exploits periods of intense skeletal remodeling. This exploitation usually begins in the metaphysis. These are the active, rapidly growing zones located near the ends of long bones, most commonly the femur in the thigh and the tibia in the lower leg. These histology panels show the microscopic failure at the heart of the cancer. Primitive mesenchymal cells mutate into malignant osteoblasts. Instead of highly structured bone, they churn out defective osteoid, forming chaotic sheets that aggressively tear apart healthy bone architecture. Inside the rigid confines of the bone cortex, this cellular destruction generates immense localized pressure. For the patient, this physically translates into severe, persistent pain that worsens at night while resting. As the tumor continues to multiply, it begins to push outward. It forms a palpable, tender mass that physically obstructs the nearby knee or shoulder joint, severely restricting the patient's mobility and their ability to bear weight. Because the peak onset aligns perfectly with puberty and active teenage life, patients and parents routinely mistake these early warning signs for standard growing pains or sports injuries, allowing the tumor to expand unchecked. When the localized pain eventually forces a clinical evaluation, the first step is to check for gross architectural abnormalities using standard X-ray imaging. This cross-section illustrates the first radiological red flag, the Codman triangle. The tumor pushes outward, lifting the periosteum away from the underlying bone cortex, creating a distinct triangular void. The X-ray reveals a second sign, sharp mineralized spicules shooting outward, known as a sunburst pattern. Immediately following the X-ray, an MRI is required. It precisely maps how far the tumor has invaded the surrounding muscles and nerves and scans the entire length of the affected limb to check for isolated tumor deposits, known as skip lesions, further up the bone. The most critical staging procedure follows, a CT scan of the lungs. Osteosarcoma sheds malignant cells directly into the bloodstream, making the dense capillary network of the lungs the primary target for early, life-threatening micrometastases. Modern imaging transforms a vague complaint of leg pain into a highly detailed map of an aggressive, staged tumor, triggering an immediate clinical race to halt systemic spread. Prior to the 1970s, the medical response to this cancer was immediate, radical amputation. These vintage prosthetic legs represent a severe mechanical approach to treatment. Yet, despite entirely removing the affected limb, patient survival remained an abysmal 20%, as microscopic metastases had usually already seeded in the lungs. Today, patients enter a three-part multidisciplinary algorithm. The first step is neoadjuvant MAP chemotherapy, a highly potent intravenous cocktail of methotrexate, doxorubicin, and cisplatin. Administering this heavy chemotherapy before surgery serves a dual biological purpose. It chemically suppresses and shrinks the primary bone tumor, while simultaneously saturating the bloodstream to hunt down and eradicate undetectable micrometastases in the lungs. Once the tumor is chemically contained, orthopedic oncologists perform limb salvage surgery. They execute a highly precise excision, removing the entire diseased bone segment while achieving completely clear negative margins. The excised bone and the adjacent joint are then replaced. Surgeons install a custom lacalic endoprosthesis, anchoring an artificial titanium joint directly into the remaining healthy bone to preserve the patient's anatomy and mobility. By combining systemic biochemical eradication with localized surgical precision, this modern protocol pushed the 5-year survival rate of osteosarcoma from 20% up to nearly 70%. Achieving a 70% survival rate requires patients to trade long-term physiological and mechanical stability in exchange for their lives. This diagram highlights the organs most vulnerable to the heavy MAP chemotherapy regimen. Doxorubicin, the A in the historical adriamycin acronym, carries a well-documented risk of dose-dependent cardiotoxicity, potentially leaving the patient with a permanently weakened heart muscle. High doses of methotrexate put extreme strain on the renal system, posing a risk of severe nephrotoxicity or kidney damage. Meanwhile, cisplatin frequently targets the inner ear, causing permanent ototoxicity and leaving young patients with high-frequency hearing loss. The limb salvage surgery introduces its own permanent vulnerabilities. A metallic endoprosthesis is an imperfect, highly stressed mechanical device, forced to operate indefinitely inside a dynamic biological host. Over decades of use, these massive implants face severe risks. The metal components can suffer from aseptic loosening as they separate from the host bone, catastrophic periprosthetic joint infections, and inevitable mechanical fatigue, all of which require complex, physically demanding revision surgeries. Surviving osteosarcoma relies on aggressive interventions that leave permanent marks. For patients who achieve a cure, the rest of their lives are spent managing the mechanical and physiological toll of the treatments that save them.
If you like this video, give us a thumbs up